Thank you everyone for joining us today and welcome to our MBS update for allied health services, including mental health services in residential aged care facilities. I'd like to start by acknowledging the traditional owners of the land in which we all meet today and to pay my respects to Aboriginal elders past, present and emerging. I would also like to extend my respect to all Aboriginal people present today. So just a little bit of housekeeping. For those of you who I haven't met before, I'm Melissa Greaney and I'm the Program Development Officer within the Training and Development team at the PHN. And before we start, I just really wanted to say that I hope everyone is doing well and looking after themselves during these stressful times. I really do appreciate that you've chosen to spend your time with us tonight. And I do hope that you find it valuable. And a big shout out to all the homeschoolers with us tonight. I've had my first taste of it and it is definitely not for the faint-hearted. So all of our attendees will be muted for the duration of this webinar, and our session today will run from 6:30 until 8 and it is being recorded. Tonight's session has 3 RACGP activity points and 1.5 ACRON points allocated, and this will be processed after the webinar. Please put any questions for the presenter or our panel in the Q&A box if you can, rather than the chat box, so we can monitor these. And any other comments can be put into the chat box. So you feel free to test the chat box by introducing yourself and what role you're in now if you feel comfortable. At the end of the session, an evaluation will pop up in your browser, and this evaluation will be also sent out tomorrow. So if you can please take the 2 minutes to complete that, we would really appreciate it so we can continue to offer you these kinds of webinars and make them the best that they can be. So without further ado, I'd like to introduce our speakers today. Tonight we have Wendy O'Meara from Lanta Consulting joining us as our key presenter. Wendy is an RN by profession and a practice manager. She has a background in general practice spanning 20 years and is currently a senior operations manager in a 20 GP practice in Victoria. We also have a panel joining us tonight. We have Kate Hurrell, the CEO of Three Tree Lodge, RACF in Lithgow, Sally Webb, Director and Physiotherapist at Tablelands Physiotherapy, and Dr. Louise McDonald at a GP at Hazelbrook General Practice. And I will be monitoring the questions that pop in throughout the session. So welcome everyone. What I will do is hand over to Wendy. Thanks.
Thank you, Mel. I'm just going to minimise that. So welcome everybody. Thank you for joining us tonight. As Mel mentioned, my name is Wendy O'Meara and I will be your presenter tonight. I always enjoy presenting relevant information to a targeted group such as yourselves, but never more so than when the information I have to present offers a real potential to achieve better outcomes for both us as providers and for the patients that we care for, and in this case, our residential aged care residents. The topic we will discuss tonight is, as you can see, an overview of the recent changes to the COVID-19 MBS numbers, with particular reference to both mental health and allied health provisions or service provisions to those residents living within our residential aged care facilities. So I'll just click on this. So at the end of tonight's presentation, the learning objectives that you should be able to or should have obtained, you should be able to discuss the important contribution that general practice plays in facilitating access to these services through allied health for our residents within the aged care facilities, particularly those with complex medical needs and those with their mental health concerns such as dementia. Describe the new GP and OMP MBS item numbers, which we're going to go through shortly, for both multidisciplinary care planning and health assessments, and also be able to locate the fact sheets for more information.
Wendy, it's Melissa here. We can't see your slides at the moment, so I'm not sure if they're sharing.
Oh, okay. Let me try again. Just go back to the webinar. Sorry.
That's okay.
I can see. I'm going to try again.
Perfect.
Now we'll go try that. How's that look, ladies?
That's great. Thank you.
Sorry about that, everybody. I'm reading away. I had no idea. Thanks, Mel. I'd also, so I'll continue. Thank you for that. I'd also like to show how to outline they outline the referral process that GPs need to take to provide this extension for these services through the initiative. And we're also going to discuss as a panelist team how with our colleagues how to deliver these collaborative services efficiently, but also to allow us to minimise the disruptions to our everyday life. So where do we start? Residential, these are the current outbreaks, I beg your pardon, in Australian residential aged care facilities. Please keep in mind this is Australian-wide. And as I was saying previously, much to our shame, most of the deaths that have occurred in residential aged care facilities have occurred within Victoria. There's a total of 685 at the moment, and this data is as of the 25th of July. At the moment, we have 5 active outbreaks, or 5 facilities with active outbreaks and 6 active resident cases. There are also 12 active staff cases. So just a bit of a snapshot about where we are at the moment. So where did all this come from? This fantastic initiative, where did it start? So it came about from a Royal Commission that was instigated on the 8th of October 2018 by Peter Cosgrove, I should say, the Governor-General of Australia. And it was in response to lots of feedback and information that the care that was given to our elderly Australians was not actually meeting the standards. So during, of course, the time the inquiry was being held, COVID-19 hit. So the inquiry directed a lot of the resources in the interim period to look at the impact of COVID in residential aged care facilities, and delivered their interim report in August 2020. The final report called for significant aged care reform. So they found that the aged care facilities in general were not meeting the needs of our elderly residents, or were not providing uniformly safe and quality care. And that's the link to the report if anyone would like to see it. So the impact of COVID-19 as you're well aware, the impact is Australian-wide, but tonight the directive is on the aged care facilities. So COVID-19 has been probably the biggest or greatest challenge that aged care facilities have ever faced. There's been a significant impact on the residents within these facilities, both physically and mentally. So physically, they have been not locked in their rooms. That sounds pretty harsh. Like they have been isolated to their rooms. They've been without family members. They've been without support. They haven't had the interaction that they've had with their other residents or the people that they live with, and mentally as well. So the concerns and the worries about what's going to happen and how long it's going to go on, as you all know, in the current environment, it's anyone's guess how long we're going to have to deal with this, and it has become part of everyday life, unfortunately. Also, the impact on the families and the staff. So families haven't been able to spend time with their parents. Again, I think this probably is more reflective to the Melbourne outbreak, because the facilities that had active cases were complete lockdown, so their family weren't able to come and see them, and many residents died without seeing family or friends, or in complete isolation. And let's not forget the staff. So they've had to manage this and try and get replacements for staff when other staff have become sick, look after the residents, and try and get their PPE and their safety standards up to scratch. So as a result of the Royal Commission report, there was many pages, hundreds of pages of recommendations. I have just chosen to select the most relevant to tonight's presentation. So recommendation number 3 from the report stated that the Australian government should urgently create MBS items to increase the provision of allied health services, including mental health, to people in aged care during the pandemic. So as a direct result of that, we've seen the implementation of these item numbers. It also recommended within that section that any barriers, whether real or perceived, to allied health professionals being able to enter the residential facilities should be removed unless justified on genuine public health grounds. So not making sure that these allied health providers are still able to come into the facilities and provide the care that the residents need. Recommendation 38 stated that to ensure residential aged care providers have a level of allied health care appropriate to each person's needs by no later than the 1st of July 2024. So I do believe that the new item numbers that we've just seen now are just going to be the start of what's going to be available for our residents. There is to be arrangement between aged care providers to have allied health service provisions as required, and to ideally employ or at least retain a range of allied health providers, and ensure provision of the care to the residents is actually in accordance with the individual needs of each resident. So looking at the care plans and ensuring the services that they are required to have are actually provided for them. And recommendation 61 was to create a series of new MBS item numbers as of the 1st of November, which they did do for allied health and mental health practitioners who are providing services to the RACF residents. And this includes psychologists, OTs, social workers, and of course you have the physios as well. Sorry, I don't know why that's not on that list. I beg your pardon, this is for the mental health. And then this should cease in June 2024 when the aged care allied health funding arrangements is established. So the government is working in the background to create some funding arrangements for allied health as an ongoing service provider for residential aged care facilities, something just to keep in mind. So we'll start with the mental health item numbers. I do know there aren't any, I don't believe there are any mental health providers with us tonight, but this is definitely relevant to the GPs who are attending, just to find out the information that they require to refer those residents. So what the data tells us, as we know, 49% of most of our residential aged care residents were diagnosed with depression in the 2018-2019 period, compared with only 12% in the community, which is a significant increase or significant difference. 53% of residential aged care facility residents were diagnosed with dementia. And again, this is a snapshot here, that's where the data has come from. These numbers are expected to escalate as a direct result of the impact COVID-19 has had on these residents within these facilities. So it's a bit scary, isn't it? From the 10th of December 2020 to the 30th of June 2022, the government has expanded the Better Access program to include residents of aged care facilities. So the Better Access program, as you know, was a program already running, which allowed mental health services to be provided. It has now expanded to include residents within the residential aged care facility. Residents diagnosed with obviously residents must be diagnosed with a mental health disorder, and these disorders can include dementia, anxiety, or depression. Plus, of course, there's a whole other range of ones, but these are the most common ones that I've identified for the benefit or for the purposes of tonight. What this means is that the residents can now access up to 20 individual psychological services per calendar year, so January to December. The flag fall item, which has been extended, so it was introduced for GPs over 12 months ago to facilitate or to encourage GPs to attend these facilities. It's now been extended to cover allied health to encourage them to attend facilities, and it's also and it can be either face-to-face at the facility or within the GP's consulting rooms to provide the service, the referral. And telehealth has been extended till the 31st of December 2021. However, we keep getting outbreaks the way we are and lockdowns, it probably will be extended even further. What this plan requires from the GPs is that obviously it requires a development of a mental health plan to be completed by the regular GP, which will then instigate the initial referral of 6 psychological sessions. Once those 6 sessions have been completed, obviously the psychologist will send the feedback back to the GP, at which time the GP should then conduct the review of the mental health plan, which again, as I said, to be completed after the initial 6 sessions. And then they can refer for a further 4 sessions. Once those 4 sessions have been completed, again, depending on the time period. So the review of the mental health plan can only be done within a 3-month period. So if the resident had access to 6 services prior to the 3-month period, then ideally the GP would wait till the 3-month interval to do the review. And now then, once the 10 initial sessions have been referred and used, they can then refer for the additional 10 sessions. Again, it should be done in 6 and 4. So 6 for the first ongoing referral with a further 4 at the end of the feedback to the GP. If a review is not claimable at the time we talked about before, it is obviously you would substitute that with a mental health consult item number, just to keep that the information relevant to what you're claiming. So benefits of allied health to residents with dementia. So it's not just about psychology. There are lots of other things that can be provided to those people. So for example, allied health plays a significant role in advising these facilities on the use of modalities other than speech. So a lot of the residents are non-verbal, so it's often cues and things that they're trying to communicate with, which allows us to identify them. They also allow assessment of cognitive difficulties, including behaviour, and offer strategies to manage, which is always great, particularly if you're working in the facility. They also provide therapies such as music, art, or sensory therapy, which can help to reduce agitation, particularly when they're newly admitted to the facilities. And it also focuses, which I think is probably the most significant of all, on retaining what abilities they still have. So maintaining the abilities to still speak or to move or to sing or to paint. So there's a whole range of things that can be improved by having these services available to these residents. It also allows the adaptation of the environment to optimise or to minimise the distress. So it allows the OTs or other providers to actually look at the environment and help them to make it a functioning environment for these residents. So Medicare item numbers that are relevant to this, obviously I've just put them here fairly quickly because we have got quite a bit to cover tonight and I don't want to waste time on things that are just all numbers. So as you can see at the moment, there's 3 item numbers for each face-to-face video or telehealth and telephone. So the first one is and they all mirror the current MBS item numbers for mental health provisions. So the first one is the preparation of mental health plan between 20 to 39 minutes, which obviously mirrors the 2700s and the 2715s. And then it scales down depending on whether they have training or not or no training. And of course scales up depending whether it's between 20 to 40 or above 40. So, and then again, the review of the mental health plan has 3 mirrored item numbers as well. So all this information is available on the links that I'm going to provide later in the presentation to allow you just to access this quickly. So obviously GPs also offer, some GPs also offer the focused psychological strategies. So again, here are the item numbers relevant to those for residents in the facility. So these are all, as I said, relative to residents which is receiving, sorry, I'm slipping over my tongue tonight, residents receiving these services within the facility or, as I said, at a GP consulting room or at a psychology consulting room.
Wendy, I've had a question come through that says, which allied health provider? OT, question mark.
Or for the patients with the dementia?
Sylvia, I might just see if we can get you on, allow you to talk. Just bear with me for 1 minute. There we go. Sylvia, are you there? Not sure if Sylvia's available.
That's okay. We can come back to that.
Yeah, well, we'll come back to that. If you have any further extensions of that question, Sylvia, just pop them in the Q&A for us and we'll make sure that that's attended to.
Yeah, thank you. So again, Medicare item numbers for clinical psychologists and then again for your registered psychologists. So as you can see, the rebates are identical to what they receive currently, but it just allows them to provide these services with the option to do the telehealth video and go to the aged care facilities. And obviously the indicator down the bottom, the flagpole, is available Having said that, of course, it's only available if the provider attends face-to-face. So they can't claim a flag fall fee or a call-out fee is what we like to call it, if they're not attending the facility, which obviously makes sense. And then you have your OT item numbers. So again, the equivalents for face-to-face, video and telephone with the rebates. Okay. And that's social worker. So as I said, the flag fall. So the flag fall was introduced 18 months ago, maybe a little bit more actually, for GPs to attend the facilities. It's now been extended to allied health as well, which is, you know, they're obviously trying really hard to promote or encourage allied health participation in this program. So, and it does help by giving that $40.35 because it does cover the costs. As it says there, it can only be claimed for the first resident. So it can't be claimed, it can be claimed per visit, but not per visit within the facility. So if you go to the facility and you see 10 residents, you can only claim the one call out fee. And that also goes if the facilities are co-located. So if you have a hostel and a nursing home and a dementia unit all within the one building, then it can only be claimed once for that call out. Okay. Allied health. So what allied health services are being offered? Allied health is probably one of the most significant roles, or play the most significant role in maintaining the quality of life for our residents. They are motivational, they are inspirational. I just wish there was a lot more of them who would attend the facilities. The practice that I work at, we have a very large aged care facility within our town, but we can't get many physios to go. So it's a real challenge to get that service. So I'm hoping that these initiatives will help. But as I said, they play a significant role in maintaining the quality of life for these residents. With COVID-19, we've seen a lack of activity and exercise, which obviously has significantly impact on their physical function, which therefore impacts on their strength, mobility and their balance, and also increases the risks of falls, along with the impact on their cognitive and mental health. As I said, increases risks of falls and hospital admissions, which we don't want our residents going to hospital when there's so much COVID-19 around. So again, same time period from the 10th of December 2020 to the 30th of June 2022, there have been some temporary item numbers introduced to improve the access to these residents. So there's been an additional 5 physical therapy services and 2 additional exercise physiology group therapy services made available. That's a mouthful, that one, which accumulates to a total of 10 individual and 10 group sessions per calendar year. So it's been implemented in recognition that residents of these facilities are at a high risk of deconditioning as a result of restricted activity. So not being able to go outside, or not being able to go with their daughter shopping, or not being able to, if they're in lockdown, not being able to even leave their bedrooms or their rooms. Reduced activity due to the lockdown, obviously. Family support is significant in maintaining their independence, and if that's removed, it does have a huge impact on them. And obviously the staff's focus has been on the infection control component, so they have had to be second best, I guess, to in the initial stages when the lockdown was, or when COVID first came in. There was such a big learning curve for the residential aged care facilities. It made it really hard to provide the care that they needed. And again, I do probably say this is more relative to Melbourne, but because of the significant amount of cases we've had down here. One thing I guess we should remember is that many residents have actually contracted and recovered from COVID-19. So they also require rehab to restore their function and mobility. They may have been bedbound for weeks and weeks and weeks recovering, and now we have to get them back up on their feet again. So to be eligible for these services, they must be currently managed under one of the following. So basically the different terminology is purely just different aspects of it. So multidisciplinary care plan, management plan, shared care plan are all pretty much the same thing, just different angles of it. And of course, the team care arrangement must be in place. And they are also available to our Aboriginal and Torres Strait Islander residents who have a 9-monthly health assessment, because that then allows to access these additional item numbers. Again, as you can see here, the only difference is the current item number of 731, which is where our GPs attend the facilities to review and participate in the facilities care plan. They now are currently billing a 731. To initiate access to the new item numbers, they must bill the 93469. If they continue to bill 731s, it won't allow the flag to Medicare of the additional item numbers being able to be accessed. And of course, the 715 is the Aboriginal Torres Strait Islander health assessment. So the 93470 can be billed in place of that when it's been done. Again, as you can see, both of these must be done face to face, and the resident, where possible, should be in attendance. So what do the changes mean? Initially, we had 5 allied health services for a full range of providers, with 8 group sessions for residents with type 2 diabetes in any combination, so exercise physiology, dietitians, diabetes educators, all those things. And I've just mentioned a few of those here. What the new program means is that there's now doubled, so 10 allied health services, but the additional 5 must be for physical therapy, and they must be face-to-face. So 5 of these services can be telehealth or telephone where appropriate, but the additional ones must be face-to-face. And these include physio, EP, and OT. Excuse abbreviations, but they're such mouthfuls. And it also has included now 10 group sessions with addition of 2 exercise physiology only. So the 2 additional are only for exercise physiology. So the MBS requirements, what's required from us? Allied health provider must be registered with the Medicare provider number. Feedback must be provided to the preferring practitioner after the first and the final service. So if the provider is referred for 6 sessions, they must refer after session 1, provide the feedback, after session 1, and then again after session 6 before we can access more visits. The referral must be on the appropriate form indicating number of services and separate referral for each provider. So I'd like to clarify this point. So when you, as a GP, do your shared care and you provide your allied health referrals, you usually use the EPC form and you put 5 visits for podiatry or 5 visits for physio. This form is adequate. So if you have done the initial referral for 5 physio or 2 dietitian and 3 physio or whatever combination you choose, you do not need to do the form again. Once Medicare, by billing the previous numbers I showed you, the 93 numbers, Medicare will identify that you are allowing or providing access to the additional item numbers without any more paperwork being involved. However, if you're referring to someone who is new to the resident, GPs, this is for you, it is really good, it is really best practice if you're able to actually do a referral letter, just a brief overview of the resident and what the services or what their needs are, so that the allied health provider has an idea of what they need to provide for those residents. The other thing I guess also we need to remember is that residential aged care facilities have their own care plans, so the allied health should have access to those when they attend, so that they can see what the GP would like plus what the facility has deemed is necessary for the residents to achieve best outcomes. And the services must be at least 20 minutes long to claim these item numbers. So what's new? The introduction of a once only initial consultation per resident. So previously you were given 5 visits and they were all rebated at the same amount. So physio would go to see a resident and they'd get the $55.10 regardless of what session how long they spent with the residents. So now they have a once off initial consultation item number, which can be provided by any of the referred services. So if a resident, for example, is seeing a physio, an ET and a EP, OT and EP, the initial consultation can be charged once per provider, but only once by each provider. So the physio, for example, can only charge it once. It is to be made up of the 10 sessions, so it is part of the total 10 sessions that are available, and it does have a high rebate. So it's $82.60 compared to $55.10. So that's another added incentives, but it must be face-to-face. And as I said, it can only be claimed by each provider engaged in the care, can be provided, but only once a year, or once per calendar year. And again, just reiterating, it must be a face-to-face for that initial consult. And there's the flag for first resident, so it's $41.65. Okay. So the relevant item numbers, because there's such a large range with the allied health, I didn't put them in. I've just put a brief summary, purely because we'll be having about 30 slides of different item numbers and it would be confusing. So again, the link that I have provided for you at the end of the presentation will give you the information that you need. So the initial consultation item numbers range between 93501 right through to 93513, depending on the service and the modality which is delivered. And the rebate's $82.60, and the additional consultation item numbers are those ranging between the ending in 24 to 38, and the rebate's $55.10, which is the current rebate for allied health services anyway. In addition, which I think is fantastic, and this is where the PHN certainly comes into its own, there has been a targeted focus on aged care homes that have had experienced a COVID-19 outbreak. So again, you do have I believe two facilities in Sydney that have had positive cases. So these facilities also have allowed, so the PHNs have been given funding to commission groups of allied health services, which are made up of physio, EP and OT, and it's allowing some group sessions. So groups, allied health services to provide further care to the residents who have been or who are living in a facility that has had an outbreak of COVID-19. And the rebates are a little bit higher again at $96.30 per group session. And subsequent $64.20, beg your pardon. So it's $96.30 for your initial and $64.20. So it is a little bit more than what they would normally be receiving. So with this funding, the allied health provider will need to meet, so with the PHN funding that I'm talking about, the group sessions, the provider will need to meet with the residential aged care staff to identify the eligible residents. So there needs to be a group of them. I think it's only 4. I think from memory it's only 4 per group, and undertake a one-on-one assessment to identify the individual needs, which I think is fantastic because it then has input from the facility and the patient and the allied health to identify what plan of action you're going to take for those residents. And then they go on to provide 6 months of twice weekly group sessions, which I think is just fantastic. Really excited about that. And I do believe that it was for participants in that group. So here's just an example of the item numbers. I've used physiotherapy tonight purely because I knew that Sally would be joining us. So this is the current arrangements. So the current numbers versus what will happen with the additional item numbers. So I'll just give you a little second to look at that. But again, as I said, I will provide that all for you later. Hope that makes sense to anyone. Please feel free to pop your questions if you have any, and we'll get to those at the end of the presentation. Now, the Aboriginal and Torres Strait Islander health assessments, just to give you an overview of what they can be done and what they can offer. So as you know, or if you don't know, they can be conducted as a GP. You can conduct these on your residents in the facilities every 9 months. And they allow a referral pathway to allied health under some more temporary item numbers. So in addition to what's already available, by having the Aboriginal health assessment, or the ATSI, excuse my terminology, but this is quicker, the ATSI health assessment allows you then to access future and further allied health numbers on top of what you can already access. I'm talking with my hands, so sorry about that. So it gives another 5 physical therapy and the 2 group exercise physiology as well. And of course, that also attracts a flag fall. So if you do have residents in the facilities who are in this demographic group, you can now charge the flag fall fee when you attend the facility to conduct the health assessment. And allow, of course, the continuation of the access to the 10 sessions by the practice nurse or the Aboriginal health worker if they are available at the facility or if they visit the facility. Something I have included here, this is for you GPs, is the DVA treatment cycle. So I'm not sure how many of you are aware of this. It has been around for over 18 months now. I actually had a question from a webinar that I did recently and they didn't know about it. So I thought I would include it just for your benefit. And I'm happy to provide any future information if anyone would like to touch base with me after. So the DVA treatment cycle was introduced in October 2019. So there you go, it's been nearly 2 years. And it allows GPs to refer DVA clients to 12 visits, a cycle, what they call a treatment cycle, which equals 12 visits or 12 months, whichever comes first. Just to add to the confusion, there can be as many treatment cycles as clinically necessary. So to put that in layman's terms, if I was to see a physio, the GP could refer me for 12 visits. If I complete those 12 visits in 12 weeks and the provider or the physio feeds that information or the feedback back to me and creates a plan for me, I can then refer for another cycle of 12 visits, and that is unlimited. So I can continue to refer every 12 weeks for 12 sessions. It is worth looking into if you're not aware of it, because it is great for those residents who do have access to this with the gold card. They must be gold card holders. So, and they can have multiple treatment cycles concurrently. So they can have a treatment cycle from a physio, and they can have a treatment cycle from an exercise physiologist, so they can have a treatment cycle from a dietitian. So this is a really valuable resource for those residents who meet this group. And initial consult must create a care plan. So they must, when they first see that resident, create a care plan, which is fed back to the GP. And the final consult must complete a cycle of care report. So there is paperwork, but I think it's really beneficial. And the paperwork is not too difficult at all. It's quite easy to complete. And obviously the residential aged care, the ability to provide it in your facilities depends on the level of care classification. So a resident in a residential aged care facility must be classified as high care to receive this when they are a resident there, if that makes sense. Okay, so what role does the GP play in all of this? So we have the information, we know what's available. What do we as GPs need to do to get this happening for our residents? So the first thing we need to do is listen to this. So the impact of COVID-19 has been significant. So general practitioners have reduced visiting residential aged care facilities. Again, whether it be across Australia, I know it's definitely the case in Melbourne because we couldn't visit them. I do believe that the impact of COVID on general practice has reduced the ability to do it, to actually get out to the facility versus the actual restriction component of it. GPs are struggling with respiratory clinics and COVID vaccinations and everything else going on. So unfortunately, the lovely residents of the aged care facilities can be impacted by that. So obviously restrictions are the limited access to facilities, whether it be because of restrictions. Many facilities are putting in restrictions anyway, only allowing family, friends, obviously the GPs, but not to the extent that they were previously. The GP's role has now moved more from a proactive to a reactive because they haven't got the time or the resources to be able to deal with the residents, because as we all know, these residents are very time consuming. So they are high need, they're multidisciplinary, they're complex. There's lots of time involved in looking after residential aged care facility residents. And many GPs don't do it. They don't have patients in the facilities. They just hand them over to someone else. So it's a very challenging role. So hopefully these additional services will help that. So I've seen a reduction in all services provided to residents, not just GPs. So there are lots of practitioners or allied health who are not attending purely because of restrictions or that they don't want to risk the residents in the facilities. So it's seen a reduction in routine visits, wound management care that the GP was providing, chronic disease management, and obviously medication reviews have also become more of a telephone thing, which, you know, is not always ideal. It's always good to do a face-to-face consultation with things, particularly medication. And it's always good to do it with the resident and the facility providers there. So what are the barriers to a GP providing care in the RACFs? So obviously there's always, and this is, please believe me, this is information is generic. It's from a report the RACGP published about why GPs don't go to facilities. So it's not specific or directed to anyone particular, because I am aware that Louise, that Kate was with us tonight, and she is a manager of a facility. Would hate to think that she thinks this is directed at anyone specifically. It's purely just what the RACGB have identified as barriers. So lack of trained staff to assist the GP or the inability to locate staff presenting to the facility unable to find someone to assist them or to access the medication charts or the information that they require. Again, as I talked about before, the complicated work that these patients or these residents mean to a GP. It's not just about in and out. They arrive at the clinic, at the facility, and then they're asked to see 3 other residents. So it can become quite complicated. And obviously the poor remuneration. It's not a lot of money to go to the facility. And even with the flag fall fee, it still doesn't really replace the opportunity the GP has if they're back at their practice. As I said, that again, significant time is spent with each resident. Quality of the care plans, there has been a lot of discussion, and we will talk about that with the panellists later, about the quality of care plans in the facilities. We find that most of the facilities' care plans are based on funding requirements. So the higher the care required, the higher the funding, and they're not always specifically for the residents' complex needs. So sometimes they can be more about the complexity of the condition versus the actual needs of the resident. But what are the incentives to this care? They are rewarding for both practitioners and residents, particularly for practitioners who have been looking after this resident for many years. And in my case, I have 20 GPs at my practice, and we have a very large facility in Gisborne, and 3 of the GPs have been there for 40 years. So a lot of the residents that they're looking after, they have known since they were in their 30s or 40s. So they've shared a lifetime of care with these residents, so they want to continue that with them now. So it's actually very rewarding. And one of my GPs takes 1 day a week and goes and sees all of his residents, which is lots of them. So he spends the whole day having lots of cups of tea. To initiate appropriate services for residents, so the ability to actually put something in place for those residents, go in there and assess and say, okay, we need to do this and we need to do that, and we're going to help you do this and we're going to get you back on your feet. So GPs have the ability to initiate those services, particularly through this fantastic program. Obviously, the increased financial incentives now through the new initiatives, but let's not forget about the Aged Care Access Initiative, which is a per financial year payment. This is only available to practices who are participating in the Practice Incentive Program, and any GP who provides up to 60 services is able to claim is paid a $1,500 fee or rebate from the government, payment, I guess. And if they achieve 140 services, they then get an additional $3,500. So it does equate to a maximum of $5,000 per year if you are seeing up 200 services, which if you look at it, there's 365 days in a year, and it's not hard to get called out every day, is it? But that's per service. So you might go to the facility once and see 10 residents. So one visit becomes 10 services. Efficient delivery. So how are we going to deliver this? How, as a general practice, are we going to make sure that we can put this into place? And this is where we're really looking forward to speaking with Louise about what her thoughts are about this. So obviously start with the basics, get some reports going through your clinical software of the last billings of care plans, the comprehensive medical assessments, and the mental health plans for all of your residents within the facilities, so that you can see where they're at. You'd be surprised how many have slipped behind a little bit, particularly the reviews of the RACF care plans. Obtain a copy of the care plan from the residential aged care facility if you can, because that will allow you to see what the actual plan is in place and allow you then to contribute to it. It's very hard to contribute to a plan that you don't know what the plan is. And then schedule routine or regular times to attend the facility to review all of your current residents. So my GPs each have one. So we have, of the 20 GPs, I have 12 of them that attend the facility. They are all allocated their own patients. So we attend the facility once a week. One GP goes and sees everyone. And then once a month, each GP has 1 hour to 2 hours, depending on how many residents they have, allocated to go to the facility and just spend time with them, have a chat, see how they're going, complete their reviews, discuss their mental health, particularly now, without being rushed. So they're actually allocated specific time within their appointment book to see those residents, along with the unplanned visits, of course. Then initiate those referrals. So look at the care plans, look at what's required, and then start referring, getting those physios and the exercise physiology and the OT and all those other services into the facility and getting our residents up and running again. And again, organising the appropriate referrals. So what can we do? As a GP, recommence or continue the regular review of your residents. That's so important. They look forward to their GPs coming. They love their GPs coming to see them. They talk about it, have their cups of little coffee cups ready or the cups of tea ready for them. Reminders are without a doubt the most efficient way to manage this program, adding reminders in your software for review of the care plans, mental health plans or health assessments. Without reminders, there is nothing to prompt us. Therefore, what we think was 3 months ago turns out to be 6 months ago or 12 months ago, and we run out of time and we miss opportunities. Assist the facilities to create the care plans. Don't just say, okay, what have you got? Yep, okay, if that's what you say, that's what it is. Give them help. Give them suggestions. I think that, Joan, my resident, would probably benefit from this, or how about we try this? Give them some background, give them some help, let them provide a care plan that's actually relevant for your patient. And of course, as a GP, we should be engaging in our other providers. So having that time with the physios, whether it be through some team care or some care plan. Case conference is the word I was trying to think of. Organise some case conferencing, have a chat with the physio and the OT. And get to know where they're at with your residents. And again, scheduling regular reviews in advance so that you ensure that adequate time is available for your residents. So booking your monthly home visits or your fortnightly home visits right ahead, 12 months ahead, so that you know when your care is going to be provided to these lovely people. And of course, always encourage the uploads of the shared health summary, because that allows the access to external providers. So if your resident's taken a hospital, as you know, it gives them the opportunity to at least have some information that can be shared. And you're also then able to access information if they have been in hospital by looking at the health summaries through the My Health record. But that's just another whole story, isn't it? So residential aged care facilities, what role do you play? How can you assist to get this moving? So obviously general practice can't do it on its own. No one can do it on its own. We all need to help. So it has to be a collaborative arrangement. The care must be collaborative. We must all work together to be able to provide these services. So residential aged care facility, the managers and the staff need to establish relationships with the visiting GPs and the allied health. So we actually have monthly meetings. So every month, the residential manager, the facility manager, and a couple of the nurses come over to our practice, and we have a meeting with the doctors and we talk about what's working for them, what's not working for them. And as a group, we work out how we can make things better for them. If they've got challenges or problems that they are finding with dealing with us, then we address them, and vice versa. if our GPs have difficulties trying to find a staff member or don't like something about what's happening, that's a fantastic opportunity to actually be able to talk about the care of those residents. So establish that relationship. Actively involve yourself in outbreak planning. So as facility providers, obviously it's a key point for you at the moment, but involve your GPs and your allied health providers in this outbreak planning. Help them to help you, or let them help you. It would be great to have the patient's or the resident's file or clinical history available to the GP and allied health. Sometimes the systems don't work, or someone else has got it and they don't know how to access it, or I'm just an agency nurse and I don't know where that's kept. So maybe look at some ways with communication with the GPs about how you're going to give that GP or the allied health access to what they need to provide best care. And that again means not just care plans, but pathology, imaging that may have come back from hospitals, discharge summaries. All that information is vital for GPs to be able to provide care or plan care for the residents, particularly when they're looking at rehab with allied health services. Invite the GPs to contribute to the care plans. I'd really love to know how many facilities out there have care plans that GPs have never contributed to, even though the wording of the 731 says contribution of a GP to a care plan. So I'm going to make that my mission to find that one out. But often invite the GP. What would you like to include as your contribution to this resident's care? All care plans should be patient-centred, not just about funding, but about the patient itself and what can help them. And of course, we should always have now, obviously everything's changing, but COVID-19 specific directives. So when we have an outbreak, the GP can contribute and say, if there is an outbreak, this is what I would like done with my residents, or this is the things I would like put in place for them, or this is how you can contact me. Or, there's lots of directives that can be put in place, almost like an emergency response plan, I guess. Have staff available to attend with the visiting GP if possible, and allied health, so that they can provide the information that's required. And obviously the IT systems is impossible to do telehealth without functioning, workable IT systems. So if you have them, great, but if you don't, it's worth looking at. It can be something as simple as an iPad that's carried around with the nurse, with the GP, so the GP and the resident and the facility can have a chat, so that it meets the telehealth requirement, but also have staff trained in being able to use it. So nothing more frustrating for a GP or allied health when they attend and they need to do a telehealth, and no one knows how to use the facility, or no one knows how to access the Skype or the Zoom or the Teams or whatever it is that you're using at your facility. Residential aged care facilities should also start recruiting service providers, because as you saw earlier in the presentation, there is going to be directives. It's going to be best practice, I guess, to actually have services already engaged within your facilities, either contracted or employed, as I said, and work on retaining the current providers. A lot of physio come or OTs come in and they build up their practice, and then for some reason, unfortunately, the aged care facilities are the first ones that go when their business builds. Involve the family in the caring of the patient, of their mum or their dad or their sister or their daughter. Ask them what they want, what they would like to see happen for their family. And of course, regular meetings. As I said, we have monthly meetings with our facilities. It can be monthly, it can be 6 monthly, it can be once a year, but an opportunity as an open forum for everyone to get together, and GPs and allied health should all become part of that. Even if you have it at the residential aged care facility and everyone comes and has a chat. Okay, so that's the facilities. Now, obviously, the allied health. Obviously going to play the most significant role in this, because it's all about funding for what services they can provide. As I said, they are an essential part of the team and they should be respected for what they provide. Allied health, we've already talked about, they enable older people to function both physically, socially and emotionally better. They give them they give them the things that they need, or the services that they need to help them stay independent. They provide a diverse range of interventions, and they prevent or slow the progression of some conditions. So there is a lot of data and research that shows that by engaging a physio or a exercise physiology, OT, any of those providers, that it can actually slow or reverse the progression of some conditions. But it also empowers our elderly to live full and active lives. So, allied health, you need to be able to access and contribute to the care plan of your facilities. Have some input, have some say in what you believe would be best for these residents. Have your initial consultation with that person, work out the plan, and then engage the facility to help you provide it. Schedule routine visits, not just once when you're needed, every month or every week, or depending whether how your business works. I guess if you have other clients, or whether you're purely working in aged care. Regular discussion, again, GPs benefit, but so do the allied health. And you should also be creating and assisting documentation of the care plan alongside the facility staff. So if you have input into that care plan, you can also have input into how the staff at the facility can help. So staff can help with doing the daily exercise routine, ensuring that the residents are doing it. They can help with diet modification or supplementation if required. And they can provide therapies if they're documented and in the client's chart, then they're more likely to be provided. So as I said before, ladies and gentlemen, these are the 3 links to the fact sheets from the MBS. So the first one is for allied health, second one is for GPs and the OMPs, and the third one is the mental health initiative. So this will give you all the information that I've covered tonight in a little bit more complicated format, as MBS does, but it gives you all the item numbers that you need to access and engage your practice managers or your practice nurses to help you sift through it all. So in a nutshell, the effects of COVID-19 on the elderly residents of Australia has been devastating. So the provision of a multidisciplinary, collaborative, person-focused plan of care is essential in addressing both the physical, mental impact of COVID-19 has had on their quality of life. And we as providers can do that. So I'm now going to invite our lovely panelists back. So I'm going to stop sharing my screen and invite the lovely Louise, Kate, and Sally back. Thank you, Louise. You're going to take your mic, put yourself on. Thanks, Louise and Kate. Hello, Kate. Welcome. How are you? Just take yourselves off mute. Sally,
yes.
Thank you.
Hi. Sorry I was late.
That's okay. You're here now. That's all that matters. So, Kate, I'm Wendy. Thank you for joining us tonight. I hope you got enough of the presentation to be able to get a gist of what it was about. So I've got some questions. The first one I'd like to ask the 3 of you as panelists is, how do you feel about this new initiative?
I think it's great. I think it's fantastic, and I think it's long overdue, and it certainly is in line with the information that's come out from the Royal Commission. I think for a long time, aged care providers have seen the benefit or the potential benefit of having allied health involved. We certainly do where I am, and I understand Wendy, and no, I won't take offence, but we do have a large number of engaged regular allied health in our service, and it has made a significant difference in the 3 or 4 years that I've been at Three Tree Lodge, and I think Sally is one of those people could probably
yes yeah
so I think it's fantastic. I think some of the barriers are going to be getting people to understand and getting GPs to engage with those and understand. So I have actually taken some notes of some of my questions that I can perhaps contribute later.
Yeah, no worries. Sally, what are your thoughts?
I agree with Kate. It is such a long overdue program, and anything that enables more access to allied health and gets those residents moving and able to, achieve their maintain their functional capacity and live active lives is fabulous.
Yeah. Louise?
Yeah, I agree. It's a great initiative. I think GPs are pretty familiar with these types of plans. It's just making them aware they can bill these item numbers and
Mm.
create the plans, and the real challenge is going to be getting the allied health.
I know. And I hear you. I know, as even in our, as I said before, we're a very affluent, Gisborne's got a very affluent population, but we can't get them either. We've got this 3 massive aged care facilities. We can't get anyone to go. They're all too busy, and they don't, basically their words are, we don't need it. We don't need the work, which is such a shame, because they're the ones that need, the residents are the ones that need it the most.
I mean, the funding is great and welcomed, but for a psychologist, say, they're going to make more money in private.
Yeah.
Because the residents can't pay the additional gap payments. Well, not many.
No, and that was something I probably should have mentioned, that the facilities, any of these item numbers don't need to be bulk billed. They can be privately charged, as long as the resident is made aware of those charges prior to the consultation. All right, ladies, so what barriers do you, so we've already discussed, so Louise has already mentioned the barrier, obviously, of getting probably the biggest barrier of getting the actual providers in the first place. Do you, Sally, perhaps see any other barriers as a provider? What do you think is stopping professions going to residential aged care facilities, apart from the fact that the money is not as good as private practice?
I think that's definitely one of them, but for us, it's just staff, just recruitment of allied health to the regions. You know, we continuously advertising and get very few applications. So it's just a matter of trying to get, you know, some more fabulous allied health providers in our area, I suppose, for us. But it's across the board. It's everywhere through the PHN. Not just our area. So
I wonder if they could do some.
And
sorry, Sally, keep going.
Sorry. No, you're right. Go.
I was just wondering if they could do some rural bonding like they do with GPs, where they actually give them, you know, they give them reduced fees for their university or their education, but they bond them to a rural area for 10 years.
I think, can I just add, I think allied health need to have some upskilling of what RACF residents need as well. I think it's all well and good to bring a psychologist in, but if you've got a patient who, as you say, can't verbalise very well, or, you know, they need upskilling, and maybe the PHN has a role there for both the physio, maybe not so much physios, but OTs and psychologists, so they can upskill on managing dementia patients, people without speech, and those kind of patients, because the money's there, people will come, but we actually want well qualified people with some experience, or who can get that experience from a course or something.
Yeah.
Louise, I think that's true. I think that's true not of allied health, but it's nursing. We can't recruit qualified nurses either in regional area. I mean, we have a bad enough trouble trying to do it across Australia and in metropolitan, but aged care in regional is even worse for nursing. And the same thing, people think you can come to nursing with no experience, no qualifications in gerontology, and you can't. It's a different, it's a specialist area for everyone, no matter what your discipline. And I think, Wendy, your comment about, and that's one of the things about the regional medical schools, where they've actually taken students out into rural environments. And yes, they don't retain all of them, but those medical students get a taste for regional life, and that's how you retain some in the regions. And I think both nursing and allied health need to do the same. In other words, encourage people through their undergraduate programs to actually engage in rural communities. And I think that's critical for all health disciplines across Australia.
Yeah, I don't see how they're going to make this system work if we can't get the providers. It's just all going to fall over.
Yeah.
Oh, thank you. So, yes, please, Louise.
Unmute herself, but I think the question she was asking earlier on was, in GP land, we can do a mental health plan but refer it to an occupational therapist. And is that what this program would also allow? Especially
yes, absolutely. Absolutely.
Yeah, and then they can use the other plan, the care plan, for their physio and OT.
Correct. So
physio and
that's exactly right. As long as it's up to the 10 sessions.
Yeah.
Louise.
That's what Sylvia was questioning.
Okay.
Not
Thank you.
In that regard, can they have a psychologist and an OT, or you'd have to just do the 5
You just, well, again, you could refer to the psychologist first or the OT, and if the OT or the psychologist wasn't working for that resident, you could then refer without having to do the paperwork side of it again. It'd be more to refer a letter to them. So how, apart from, as Louise just mentioned, which is a fantastic idea about the PHMs getting involved in recruiting, or Kate mentioned recruiting the allied health and the undergraduate program, how else can the PHN assist in making this program work?
I think it's upskilling of allied health. I mean, we've got another really fabulous program for eating disorders, but we haven't got enough dietitians or psychologists that have eating disorder knowledge.
Training, yeah.
But the same's with RACF. And it doesn't have to be our PHN, it can be any PHN that's doing an upskilling program. We can all do it via Zoom now.
That's way of life now, isn't it? We're all getting at it.
Maybe our PHN can find out what upskilling programs for allied health are happening across the country. And for
but even Louise, tapping into things like the MOOC, the online learning modules around dementia care running out of UTAS, for example, are easy. Anybody can enroll. They might not be specific to a discipline, but they will at least give an understanding of dementia care, communication with someone with dementia. So it's about even finding those online courses that already exist through dementia care, UTAS, or whatever, and then providing those and disseminating that information out to both allied health, GPs, and RACs themselves.
Even just a resource. Some kind of resource that has all those courses listed so that it can be, as you said, disseminated to all the general practices and allied health, and they can access it. That's a great idea.
And I think that having the GP will turn up to the RACF, the staff will say we're going to do a plan, or should we do a plan? We're not going to know who's willing to come into the facility. I'm a handful of physios that will come into these facilities. So the RACFs and the PHN need to collate such
a local directory, perhaps. A
directory, yeah. With perhaps those that have got extra courses done, like Kate was suggesting.
Do you have the health path? Do you use health pathways up there, Louise?
Yeah, pretty much in the lead of health pathways, so I know it very well.
Yeah.
But we don't have. We could have an RACF allied health resource page, but we have to find the allied health. Put them on the page.
Yeah.
And then we can then annotate their expertise or their skills. That would be really helpful, and our team would be happy to do that. But it's a lot of work, and I think if the PHN could coordinate who's using who, each local health district, a local government area could have a list. So we would have the Blue Mountains, Lithgow, Hawkesbury and Penrith, for example. Here's your physios, here's your OTs and your psychologists that have some training or experience in RACF residents.
Yeah, that's fantastic. I just popped myself on video. I think there's some fantastic suggestions there, and we, as the PHN, can certainly look at creating a directory of sorts of with the providers that are prepared to work in our RACFs first and foremost. And I really like the idea of a resource or central place where we can house that training, those online training courses for upskilling purposes. So certainly, my intention from tonight is to take away some of those suggestions and absolutely share those where I need to try and make a start on some of these so we can help make this a successful initiative.
And Melissa, I actually texted Janice a few minutes ago and just said, I also think this sort of education, if we can organise, I know this is through the PHM, but I'm thinking about organising it within Lithgow, like almost having a dedicated session for because we've probably only got, for example, in my region, one of the benefits of working regionally is I've probably got 4 or 5 GPs only. Some of those also work in the other aged care service. And it would be good to have this. And Wendy, I really congratulate you on that concept of meeting regularly with the practices about what's working, what's not working, and actually nutting those issues out, because I think the only way for all the recommendations of the Royal Commission, one of the only ways we're actually going to improve health outcomes for people in residential aged care is through collaboration, breaking down of barriers, of interprofessional barriers, And I still find that as a RACS person, probably one of the most frustrating things, that I don't see interdisciplinary collaboration and respect all the time. And I think that is the critical thing to actually getting collaborative plans developed. And I couldn't concur with you more. You made a comment tonight about care plans are very funded driven through ACFI, RCI, or whatever is the current norm. We don't have those. I've resisted to the nth degree to a lot of issues with the regulator. But we don't. We actually write them in the first person. They're all about the person by name. But my concern is we struggle to get GPs and this is not just me, this is my experience of 20 odd years working in the sector across a range of regions as a consultant. Getting GPs to actually sit down for 20 minutes and have a case conference. And I understand the barriers of running a GP practice, particularly in a regional environment. This is not an answer of GPs, but actually being able to sit down around a table collaboratively and work out the plan of care. That to me is the critical and crux, whether it be medication management, allied health, psychotropic management, or whatever else you want to talk about, palliative care, end of life planning. That only happens when everybody takes 20 minutes to sit around the table. And to me, if we can find a way to engage all GPs or to reduce barriers to enable that to happen better, that is the crux to better health outcomes for older people in RACS.
Louise, what do you think about that?
I think I've been called into the one resident aged care facility that I attend a handful of times, and it was with a particularly complicated patient and their family, and it was a family conference, I think you call it. But I think those kind of regular, if we had a regular meeting with, doing 3 or 4 residents at a time, with some allied health visiting, because there's so many things the allied health can teach us, we'd start learning what they can do, and then we'd replicate that with other patients. It would be a very good teaching exercise for everyone, and as you say, Kate, solve a lot of the problems.
And I think also including pharmacy in that, Louise. I think in all of this conversation, we've left out pharmacy, and I see pharmacists as being a critical component around both quality of life, de-prescribing, psychotropic management, whatever it might be. In all of this, one of the sad things I'm seeing is the pharmacist isn't included necessarily in this. Now, I know there are item numbers for that. I know there's a lot of stuff rolling out through the Royal Commission around pharmacists being actively engaged by, we actually employ a pharmacist 2 hours a week.
That's great.
Who reviews every new admission, who looks at everybody comes back from hospital, who helps manage our psychotropic and antimicrobial register. But that's something we're paying for because I see the value of it. And I think that's the other person that's the one thing I think that's missing out of this allied health. And if I was going to advocate for anything else, I would advocate for that pharmacist. Sally can be talking about falls risk, but in actual fact, that falls risk may well be related
to the medication they're on.
The only catch with doing a big family conference or whatever you want to call it is there's no billing for us at all.
And that's the problem, Louise. And I really understand the barriers. I understand time constraints. I understand remuneration constraints. Just the ability to coordinate a GP, an allied health, a pharmacist all at one time. My question is, do we use forums like this enough? Like we've been conducting, we invite Louise GP to every family conference. They're very rare to attend. And the issue is when they do, it's great that the outcomes from those meetings are so much richer, and there's the family as well who feel better and better connected to it. And often the other thing, Wendy, you made the comment that your GPs often have a longitudinal. One of the things I know from as a consultant working in Metropolitan is that a lot of residents enter aged care and they lose their GP of 20, 30 years. And so the poor GP has very little history, and that's where the family is a rich history giver. And so I think that's that continuity of medical care comes back to the whole IT, my healthcare record, all those things that we talk about all the time. They're missing. And if we could get some of those links right, Louise, I mean, it must be really hard to take over someone who's 85, who's non-verbal or highly confused with no history. I mean, it must be incredibly difficult.
That is a really good point, and it happens all the time.
Yeah.
I have followed my patients into RACFs, but majority have gone elsewhere. And then I'll be getting a new resident next week. I've never met her before, never met her family, start from scratch. So it is.
Do we get, Louise, do you get allocated time for those residents? So we send our GP up for an hour every time they get a new resident to actually meet them, conduct a CMA and medication review, the whole thing. Do you get time to do that?
I mean, I do it on my day off.
So I was going to say, and Wendy, my experience, and I'm not talking about Lithgow because I really don't want to, but my experience is that some admissions, GP will see the resident for 10 minutes and they will rely on a discharge summary, a very outdated CMA, and what limited history the care staff have had to actually gain from the family within a short period of time.
So again, that whole case conferencing thing would be so beneficial then.
I actually think it's the pinnacle to health outcomes.
Louise, you mentioned before you can't charge for family conferences, but you can charge a case conference if there's 2 providers.
Yeah, we'd have to organise it, and it's that organising. You know, who's going to do that? I have to organise it to charge that item number
on your day off. Well, yeah, you actually get more when you organise.
Pardon?
To organise is actually worth more money than a GP who's participating in one that's organised for them.
Oh, it's a lot more if you organise it. But
and we have telehealth. So we do telehealth with endocrinologists at the nursing home, with geriatricians at the nursing home. So it's about again,
are you allowed to charge those conferences?
Absolutely. So they're telehealth, so they're different again. So the providers can charge as well. I'll send you through information if you want to send me your email. Sorry, Sally?
An allied health charge for case conferences?
No, unfortunately, but that's going to have to change. Let's petition the government.
I agree, Wendy, that does need to change.
Let's do that.
You can't expect an allied health professional, with all due respect, the aged care facility can't charge them either.
No.
And if I come back to Wendy's point, one of the things that the PHNs identify across Australia is that they often go into racks and they can't find anybody and there aren't enough qualified staff. And I'm taking a broad approach. It doesn't happen in our organisation. We have RNs on duty all the time, but I understand, and I'm sure Louise would have gone to organisations where it's an agency person or there's no one there that can actually give Louise the information.
I've had 3 days off is the usual line.
Yeah. But again, Wendy, and there's probably people not online, but I think the other thing is for GPs to recognise that the way aged care is funded too, it's really important. You made a comment about going in the same day every time, knowing it's planned. So if we know a GP is coming at a certain time, we'll either allocate additional staffing or the clinical manager who oversees the RNs will be available for that troubleshooting and problem solving. Yeah. But when GPs don't set up that structure of coming regularly, or they come at 5 o'clock on a Friday night or on a Sunday afternoon, I'm not funded. We're all 70% of us are in operational loss. I can't then have additional clinicians available on a Sunday afternoon to do a round because it suits the GP either. So this notion of collaboration, of recognising the barriers for everyone, which is why I love your idea of meeting monthly with the GPs and saying what's working and what's not. I think it's fantastic.
Yeah, best thing we ever did.
Yeah, I would agree. I've got it down as, can we do that here?
Absolutely. Send them an invite, put lunch on, get them to come round. They'll come.
We'll come.
What did you say, Sally?
Louise will go on a day off.
So it's even if I initiated that, I don't know that the RACF would do it. You're saying they come to your practice, Wendy? The RACF?
No, so they come to the practice in the conference room. We have lunch. We have the facility manager. She comes. Sometimes she brings different shift nurses with her, whoever's on shift. Sometimes I'll bring in someone else who's relevant, the IT guy, for example, if we're having IT issues, and we can nut everything out. It doesn't take long, and then before we leave, we have the next meeting penciled in the diary.
And I think, Wendy, that's wonderful. And Louise, I can speak for myself and some of my close colleagues who run other services. We would absolutely welcome, I would welcome that opportunity to meet regularly with GPs about how can we better improve communication. You know, when you want to come on a Sunday, that's a problem for us. So how can we work around that to meet your practice needs and my needs simultaneously? But for that to happen, there needs to be equal respect. So it's about this respect about everybody's barriers. And it's like Sally, you know, if you want Sally to be there on a Sunday afternoon, that's a challenge for Sally if she can't recruit.
Sally,
Sally.
Sally, how do you feel about all this? So as an allied health, listening to what we're talking about, would that be something that you think would benefit your residents? And what do you think you would do differently now that these initiatives are there? Is it going to improve what service you provide?
In terms of the collaboration, I think it's fabulous. It's just, and I do agree, just if they just book it in as a structured thing once a month or whatever, we just have to schedule around it. And if it's put in, it just happens. That's just how it works. And, you know, go back to the old hospital days where you'd all meet and have a case conference about, you know, 4 or 5 different cases.
Yeah.
We all did it when we first left uni and all that sort of stuff. So I'm sure everyone remembers how to do it. And I'm sure maybe the public health, you know, they still do it in hospitals. And I think that would make a massive difference for the residents as well. Get what they need and, you know, have a voice if need be. And in terms of the extra physio or EP or sessions, I think it just allows more access, more capacity for the physios to do what they actually want to do with the residents, keep them moving and doing their exercises. And it is amazing when you have that time that you can spend with them. You know, you can get great results, and it is much more rewarding for the physios when they're sort of really structured with the ACFI things where they've just got to do set. You know, we're basically with ACFI, you know, we're told we must do these 3 options for pain relief, and it's ridiculous. It's you know, there's no research behind it. It's shocking. And so for us as physios, we feel like we've just lost any autonomy. We're just told you just do this if they've got pain.
Sally, we feel the same as nurses, don't worry.
Yeah, it's just a silly system.
Going forward, if a GP is going to have to ring the physios, the local physios that they use, and say, are you willing to go to an aged care facility? Or who's going to do that? How are the allied health out there, those that aren't attending tonight, knowing about this? And how are we going to know who will go to the RACFs? I don't have time to ring all my physios. And I have to ring all the other people. Who's going to do that?
Maybe that's where the PHN can assist by putting in some kind of local networking, or like we said before, even as just a contact sheet or a list of providers who are willing to attend residential aged care facilities.
Louise, also the RACs itself should, I mean, like, for example, I regularly engage. I don't pull them in when I need them. I regularly engage a speech therapist, a dietitian, an exercise physiologist, the physiotherapist. I have psychology in, we have podiatry in, and they're all engaged on set contracts, which we pay for regardless of what we've got at the time, okay?
But they don't have time to come and do more. I think some of the RACFs have got a physio there who sees the residents twice a year. One resident twice a year. That's how few visits they get. So, and then to say to that physio, okay, can you do 12 sessions with Mrs. So-and-so? They won't have the allied health to do it.
The problem, Louise, too, is that a large number of residential aged care services, as Sally rightly pointed out, it's driven by ACFI. So for me, it's not necessarily driven by ACFI. Sally and I work really closely together around how we manage that. And we've come up even recently with some different approaches to that. So I get the funding, but allow their physios to do more of what physios do. But the problem is they often engage in large allied health providers, so large organisations.
Yep.
And maybe that's a role for the PHN. Maybe there's a role for the PHN in terms of actually having conversations with these large allied health providers that, for example, a large group of aged care providers engage X organisation to provide all their allied health, mainly to with all due respect, often to maximise ACFI. But maybe that's where the conversation needs to happen in those organisations, Louise, and maybe that's a role for the PHN to be engaging those larger organisations, and I don't want to say online who they are, but there are probably, Sally would know, 4 or 5 major organisations who say, we'll provide you with X, and maybe that's where that conversation needs to happen, Louise, as well.
Maybe. But I also might want, you know, my favourite physio to go there, but they won't have the resources or time to go.
I know. It's an access issue again.
Melissa, would you like to comment on that?
Sure. I just wanted to not be.
I saw the message. I thought it'd be nice for everyone.
Absolutely, and I've just been messaging Yolandi as we're speaking, and she says absolutely the PHN can certainly look into supporting with the contact. And I mean, to get a directory together, we would need to make that contact and start engaging more to be able to even do that. So, you know, and we do have other committees and other stakeholder groups that we can reach out to and try and put some plan in place about to support or alleviate some of these barriers, or make the access a little bit easier. And, you know, there's some brilliant things tonight. So I'm really glad we're recording this session. For those people that didn't make it on the call tonight, you know, to send this session off to those people as well, and really start spreading the word about what we can do. I think collaboration is key. And yeah, we'll do what we can to support that. And there's some really amazing suggestions. So I do appreciate those, and yeah, we'll certainly be catching up about that tomorrow to talk through some of those and where to next and what we can certainly look at dropping into our work plans.
Louise, can I just say, do you think maybe that the you could engage like the physio who's already at the, you know, they've already got people who are already providing the physio services. I know you said that sometimes only twice a year, but they might be able to do the extra sessions, or even just their local physio who they normally would have seen. Maybe they would be happy to go in. Like, you never, there might be an opportunity for them to get into the facilities, and they might like them better than the big groups, maybe.
Well, I think we'll do both, but first up would be, I would ask the RACF, who, you know, I've used physios occasionally, and they say, oh, you're allowed 2 visits or 3 visits, but now we've got a lot more. So I'm sure they will use those big corporations that are coming, but it is good to perhaps have a list who else would like to come, because we don't want to give all the allied health money to these big corporations either. We want to support our local physios. I have no idea what OT expertise out there with RACF residents exists. I use OTs rarely, mainly for children, but if there's one in the Blue Mountains that knows about dementia, please send them my way. Yeah.
Sally, is your OT, you have an OT, don't you, or you did?
Yep. Well, she can go and see you, Louise, because she's in Penrith.
Okay, but will she come up to the Blue Mountains? Probably too far.
Yeah, she won't. No, she comes to Lithgow, so she comes through. Okay. But at the moment she's not, because of lockdown. Like, she's keeping herself on the other side of the big wall.
And Louise,
And ladies, we've just had a comment from Cecile. So thank you, Cecile. I'm just going to read it. She just mentioned that there are 2 options. The same physiotherapist can be approached and requested to provide individualised sessions and be paid privately. And she said she's used this option many times. It's a win-win for both physio residents and the GPs. And she's also said the second option is to engage a separate physio from outside, not attractive to the local physio, as the physio will find more cost-efficient physios see more residents in one session. So about attracting an external provider, I guess. Thank you, Cecile. That's really great. I think it's the case of looking outside the square with everything we're offering now and getting together. Already, as the 3 heads together tonight have already solved quite a few issues. So I think if we can get that collaboration going and get the GPs and the allied health and the facilities together, it actually might have a chance of getting this to work.
Absolutely. Janice, did you have anything you wanted to add?
When Sally was just talking regarding engagement with the facilities, I think that's a really good place for the PHN to start in terms of auditing what allied health is currently available and identify then some gaps as well. I know, Kate, when you mentioned about up in Lithgow, but I think this, as we know, there's such variability across the aged care facilities as well. So looking at what, taking advantage of the allied health that would like to take up this opportunity, and then looking at where we can sort of slot in and finding out where those gaps, so we can sort of look at our own contact list of allied health providers and approaching those. And I certainly like Dr. Din's suggestion on the chat about looking outside the box, I guess, outside the square.
And maybe it's about advertising the PHN, making local GP and local allied health professionals aware who might not be engaged in PHN activities or might not be aware that there are new item numbers, and they should be seeking to put their hands up or a level of expertise up. Because maybe there's an allied health professional someone who doesn't know that there is funding items now available for residential aged care. So maybe it's about actually advertising what's available, and we might call people. Because like Louise, I worked in the UK where we worked extensively with an OT, someone Sally actually knows, so mutual co-had, and her contribution within the residential aged care environment was monumental. I've never had an OT working alongside me in a geriatric rehab like that, and it was amazing.
Wendy, I remember on your last session, you had a physio on your panel. I think it was a physio, and his whole business model is based around RACF, correct?
I was actually just going to say that, Melissa. So when he started in business, he had no clients, so he thought, okay, well, I'll try the residential aged care facility because there's always work, and he's built a real business out of it. So I agree. I think the actual potential for physios who want to build a better business model to actually listen to the information and perhaps share the contacts again. Someone like Nathan, who's already been there and done it, or has gone that path, put them in touch with people that can actually connect each other. You've got facilities that are screaming for physios, and you've got physios who've got no work. How do we get the two together?
Yeah, absolutely.
And now's a really good time. We're seeing a huge regional movement. We're seeing a whole pile of people who don't want to live in metropolitan because of COVID. So we are seeing a move. I've seen it. We've had 2 or 3 RNs who have actually moved to Lithgow permanently. And I think now is an opportunistic time to start advertising for young allied health professionals who want to develop careers and businesses, as you said, Wendy, within the aged care context. Now's the time, particularly in a regional, come to the country. It's cheaper to live and there's plenty of work, and you can build your business. It's almost that sort of market right now.
I think that is a PHN role, because there's 2 comments here. Who is doing the work to recruit allied health to do this work? And then someone's put, no point in doing a plan at a great effort if no allied health available. And we need allied health, and we need upskilled allied health, and we need a directory of those upskilled allied health.
And we've got another comment from Peter, my boss. Hi, Pete. He said that Nathan, the physio that we were talking about previously, he said the residents were just so grateful for anything any small improvement that the physio can offer. So getting something, delivering something to someone is better than sitting around, not doing anything. I think if we can find a way to connect these groups, and maybe Mel, that's where the PHN can certainly, or Janice, where you've got, if you've got services to put something together, put perhaps a flyer out to invite more allied health to even these webinars, so they're at least aware of the item numbers, and perhaps we could focus more on getting, Kate and Louise to talk about the business model that with GPs and aged care facilities can offer them.
David's written, he's a GP in Hawkesbury. I know one physio in Richmond who wants to work in RACF but didn't get the contract, which went to a larger group, so isn't able to go in. Now, if RACFs are having those blocks, that's got to be removed.
And Louise, that's what I was saying. It's a very difficult, Sally and I have had this conversation. As we get mergers and acquisitions happening in the residential aged care service, the decision about who will be the allied health provider is actually taken away from a local level. Okay. And so larger groups will often engage an external provider across all of their services.
Well,
Okay.
is this plan allowing us to choose who comes in though? Isn't it? So David could engage that physio enrichment to come in.
Correct.
That's
The
right.
GP
You
Correct.
refer
needs to know
directly to
that.
him.
You write on the plan
Yeah.
who you want to come in, and the RSF can't stop them coming in.
That's right.
No, you cannot. And so, and I think, and that's why I think, Melissa, it's important to engage with those larger providers. Okay. But again, Louise, you're absolutely right. I mean, you can have any provider coming in to do, a resident has a choice of provider.
So this list that we're going to collate, Melissa, is really crucial. It is.
Giving me a whole lot of extra work, Louise.
But I know for the RSCFs, it's going to be easier just to use the big people in town.
Yeah.
And
I
they
think
very
it's a shame. The intention was to get more allied health people here tonight, and I'm glad we're running this session again, 2 times before the end of the year. So certainly I would welcome any suggestions from you offline on how we can try and engage more people from that sector to come to this. And maybe it is about pitching that it could be a business model for them and something that's a little bit more fruitful if they haven't thought of it, because I can guarantee you there's plenty of allied health providers out there that don't know this exists. I can guarantee it. It's news to a lot of us. So now in the interest of time, I know we've gone past 8 o'clock, but I just didn't want to stop that chat. It was so valuable. Sylvia, I just wanted to double check with you that your questions have all been answered. They were from earlier on in the presentation about which allied health provider.
Louise has covered that.
Yes, thank you. Yes, thank you. They have. Ta.
Perfect. Well, look, I just wanted to say thank you to everybody. I think particularly the last half an hour was so just really fruitful and full of so many gold nuggets of ideas and suggestions, and the collaboration online tonight is amazing. So thank you for everyone taking the time to spend the hour and a half with us, and to the panel and Wendy for helping to coordinate this session. After we end this webinar, an evaluation will pop up in your browser if you are sticking around for a few minutes. It's not always instantaneous, but I will also send that out in the following days with a certificate to those that attended. And please, we really would love your feedback, good, bad, and in between. And if you have any suggestions about these future sessions to help get this moving, I think we can really build on the outcome each session that we deliver. So yeah, any suggestions would be really welcome in that evaluation. So on that note, everyone, thank you so much, and good night, and yeah, have a good evening and a good rest of the week.
Thank you. Lovely to
Thank
meet
you
you all.
so
Take
much.
care.
Bye.
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 Thanks, Mel. Thanks, Rob.
Bye.
Thank you.